psychological break in the exam. Neck, back, breasts, abdomen, and arms. Inspect all of these and palpate them for any evidence of trauma, lacerations, bruises, abrasions, tenderness, etc. Record any significant findings. Examine the hands. Collect fingernail scrapings using wooden toothpicks, one for each hand. The patient may do this herself with you observing. Place the scrapings and the toothpicks in 2 envelopes, one for the right hand, one for the left hand. Label and seal them. Pubic hair combings. Lightly comb the pubic hair over a plain white piece of paper. Fold the comb and any loose hairs into the paper. Place it in an envelope, label it, and seal it. There may not be any loose hairs. Don't pluck hairs from the pubic area to serve as controls. If the law enforcement jurisdiction in which you are located later requires plucked hairs, they can ask for them at that time. Inspect the vulva. Using good light, carefully inspect the vulva for signs of trauma, lacerations, bruises, abrasions, and so forth. Note the status of the hymen. Application of toluidine blue dye, rinsed with vinegar, can highlight recent trauma. The dye is retained by metabolically active cells. Visualize the cervix. After moistening the vaginal speculum with warm water, insert it into the vagina and inspect the vagina and cervix for signs of trauma. Obtain a vaginal swab. Using 2 dry cotton-tipped applicators, swab the vaginal walls and the posterior fornix, the area beneath the cervix. Smear this specimen on a glass slide and allow it to air dry, then place it in a cardboard slide holder. Label and seal the slide holder. Let the cotton swabs air dry and then place them in an envelope. Label and seal the envelope. Do not try to examine the vaginal or cervical specimens for motile sperm unless you are experienced in this technique. Forensic pathologists will examine the dried slides, and their skills are considerable. You may jeopardize later legal proceedings if you inartfully look for motile sperm and reach conclusions which are different than those of the forensic pathologist. From this perspective, it is better to leave the microscopic examinations to the experts unless you have experience and training in this area. Use your chlamydia test to obtain a cervical specimen. Use a dry cotton swab and chocolate agar plate or other suitable technique to obtain a specimen from the endocervical canal. Label the plate and send it to your laboratory. In the case of rectal assault, inspect carefully for tears or breaks in the skin of the rectum. Toluidine blue dye can be helpful. An anoscope can be used to inspect the lower rectum. Use 2 cotton-tipped applicators, moistened with distilled water, to obtain a specimen from just inside the rectal sphincter. Smear this specimen on a glass slide, allow it to air dry, and place it in a cardboard slide holder. Label and seal the slide holder. Let the cotton swabs air dry, and then place them in an envelope. Label and seal the envelope. Use another moistened cotton-tipped applicator and a chocolate agar plate to test your patient for gonorrhea. Send this specimen to the lab. After collecting all of your specimens, perform a bimanual exam. Using the lubricating jelly, palpate each of the pelvic structures, noting any enlargement or tenderness. Once the pelvic examination is completed, a cleansing douche of betadine mixed with water may be appreciated by the patient. 50 to 100 cc's of solution can be used to rinse the vagina using a 30 or 50 cc syringe. Collect the rinse in the emesis basin and discard it. Let the patient shower and change clothes. This is important for her psychological health. Usually there are no major physical injuries after a sexual assault, but the psychological injuries can be considerable. A part of your treatment will be to reassure her that she's okay and to assist her in the cleansing process, both physical and mental. Once the specimens are collected, she should be given the opportunity to shower and change clothes, in a sense washing away some of the unpleasantness of her recent experience. Some women will decline, preferring to shower later, but many will appreciate the offer and will feel better afterwards. Some blood and urine tests are appropriate. A VDRL or RPR test for syphilis should be done. That's repeated in 1 month. Hepatitis B test is done. That also is repeated in 1 month. An HIV test is performed. It's repeated in 1 month and again at 6 months. A pregnancy test should be done and repeated weekly until the next menstrual flow. Obtain 1 extra red top tube for the investigator. Also, place 4 to 5 drops of the patient's blood taken from the needle or drawn from one of the red top tubes and place them on a piece of filter paper. Let them air dry. Place the filter paper in an envelope, label and seal it. You should offer antibiotics. The risk of acquiring gonorrhea from a sexual assault is approximately 6 to 12% according to the CDC, and the risk of acquiring chlamydia is probably a little bit higher. The risk of acquiring syphilis is estimated to be about 3%. The risk of developing AIDS from a sexual assault can't be precisely estimated as it depends on too many factors, but is considered to be very, very low. Standard prophylaxis for STDs consists of the following: ceftriaxone 125 mg intramuscularly, plus azithromycin 1 gram by mouth once, plus metronidazole 2 grams PO once. Doxycycline 100 mg by mouth twice a day for 7 days can be substituted for the azithromycin. Post-exposure hepatitis B vaccination should adequately protect against HBV. Hepatitis B vaccine should be administered to victims of sexual assault at the time of the initial exam. Follow-up doses of vaccine should be administered 1 to 2 and 4 to 6 months after the first dose. For those known to have completed a full HBV vaccination program, additional hepatitis B vaccine need not be given. Offer emergency contraception. The exact risk of pregnancy following a sexual assault is estimated to be about 2 to 4%, but depends to a large extent on where the woman was in her menstrual cycle and, of course, whether she was protected by some contraceptive method. Taking 2 medium-strength birth control pills, such as Loदैन, right away and again 12 hours later has been used successfully by many physicians to prevent pregnancy. Alternatively, 4 Loदैन could be taken immediately and again 12 hours later. Such a dosage is well tolerated by most women, but about half will experience significant nausea which might require anti-nausea medication. After using this protocol, the woman's normal menstrual cycle should not be disturbed and she will not have any withdrawal bleeding after she completes this 4-pill regimen. This method reduces the risk of pregnancy by about 75%. Should a pregnancy occur despite the use of emergency contraception, there is no evidence of any harm to the fetus. You need to advise your patient of these issues and let her decide whether she wishes to take emergency contraception. Whatever her decision, you should document in the medical record your discussion and her decision. About a month after the assault, the patient should be re-examined for any lingering injury and also to provide reassurance that at least physically everything is totally back to normal. At this time, she will have had a menstrual flow typically, and she can have her follow-up labs such as HIV, VDRL, hepatitis B done at the same time. This will also allow you an opportunity to see how she is dealing with the psychological issues related to the assault. Ideally, serologic tests for syphilis and HIV infection should be repeated 6, 12, and 24 weeks after the assault if the initial test results were negative. For psychological reasons, some women may need to be seen earlier than this time to reassess their adaptation to this trauma. After the patient has been examined and treated and all specimens collected, she may be released. She should not be released alone, but rather in the company of someone she knows and trusts. It's important that she feels she is going to a safe place. Write your report. Make this factual, but it need not be lengthy. Don't draw legal conclusions about whether a sexual assault occurred or did not occur. That's for the courts to decide. Give the evidence to the investigator. Using a proper chain of custody form, sign over the evidence to the law enforcement representative consisting of clothing, copy of consent to release information, a copy of your medical report, glass slides from the oral specimen, vaginal specimen, and rectal specimen, swabs from the mouth and the vagina and rectum, filter paper with saliva, filter paper with 4 to 5 drops of the patient's blood, combings of head hair, combings of pubic hair, and 1 red top tube of the patient's blood. Give the specimens to your lab. The laboratory specimens which you obtain for patient care reasons should go to your laboratory, but may be handled in the routine fashion and not following a chain of custody procedure. They'll typically consist of a gonorrhea plate from the mouth, the cervix, the rectum, a chlamydia test kit from the cervix, pregnancy test specimen, and a red top tube for VDRL, hepatitis B, and HIV test. Give prescriptions and instructions to the patient. The patient should have everything she needs to get her follow-up medications. In addition, she should have written instructions on where to be and for what purpose. Children who are victims of sexual assault need special attention and may require some modifications of the general outline. Small children may not have an appreciation of exactly what happened to them or may be unable to express themselves. Some experienced examiners will have the child use dolls to demonstrate what happened. During sexual assault of a prepubertal child, serious internal injuries may occur, including laceration of the vaginal wall and tearing of the uterus from its supports to the top of the vagina. Rectal injury may occur. Because of this, it may be necessary to obtain other tests, such as an upright abdomen looking for free air in the abdomen, or to examine a child under anesthesia to determine the extent of the injuries. Intra-abdominal injuries properly diagnosed and treated will usually have an excellent prognosis. The same injuries diagnosed after peritonitis has become well established are more grave.